Thank you very much for having me here. I don't get any cool videos. I get close to one picture. So I'm Andrew Kovler, and I'm going to talk about kind of all the drugs that we give for stomach cancer. And I'll cover a fair bit of them. Disclosure slide, all the research funding goes to the UW, so they get all the money. Objectives. So I'm going to talk about chemotherapy, I'm going to talk about targeted treatments, and then I'm going to talk about immunotherapy. And as I go through them, I'll try and explain what all those things are actually doing and how that works. So what is chemotherapy? To start there, I'm actually going to go back up and talk about cell division and DNA, and this at least gave me an excuse to wear my DNA tie. I'm figuring out how the pointer works. 1 second. Okay, so DNA is, the genetic code that's in all of our cells that programs them what to do, pretty much everything but a red blood cell. So it spins around, and you have these adenosines and thymines and guanines and cysteines, which I wouldn't remember probably the names. There was ATCGs that pair up and go through and code what cells do and programs them. So that's one step thing to know, and most people probably know that in today's world. And then there is microtubules that move just about everything, and in this case what we're looking at mostly moving the chromosomes around in the cells. And this all becomes important as we move into cell division. So cancer grows, and if cancer is going to grow, you have to have cells duplicate. And in doing that, the DNA eventually doubles itself up, and then the microtubules will line them up in the middle, and then will split the cells apart. So each cell gets a copy of the DNA. In the cancer cell's perspective, each gets a copy of incorrect DNA that's going to tell it to continue to grow too fast. So when we talk about chemotherapy, this is mostly what we talk about are things that target this aspect of cell division, which is where, when we get to it, most of the side effects come from. So the two drugs that I started with, a little bit older, cisplatin is one of the oldest drugs that are classically chemotherapy. It has actual platinum in it. And what it does is it binds to the DNA and kind of locks it up. So for DNA to replicate, it has to come apart, and then makes a copy of itself, and then gets put back together. So that is one location where you block this, and then the cell can't divide. So that stops DNA replication, and then that stops cells from dividing. So that's how platinum drugs work. So there's a drug out there called oxaliplatin, there's cisplatin, and that's how they work. Docetaxel sounds like also Paclitaxel, so those are called taxanes. They come from plants. And what they do is the microtubule structure that divides the cells is dynamic. It keeps building bigger, it gets smaller, it moves things around. And what these things do is they cap it so it can't do that. So it forms, and then it can't split apart. So in that sense, then the DNA can't start dividing, and it can't go anywhere. So that's when we talk about chemotherapy. These are four of the main drugs that we talk about that are used in this cancer. There's also Paclitaxel, which I am putting in a picture there. And it's, exactly how targeting works, that oxaliplatin is more of a GI drug than doesn't really work in breast cancer is a little bit, I'm going to say to me, unclear. It is, so not all chemotherapy just works in all diseases. But there's various drugs that, in the end, have been found to work against gastric cancer cells, and frankly, a lot of the GI system cancers. So you'll hear these drugs if you go into colon cancer and stuff like this. 5-fluorouracil, or 5-FU, is a drug that's one of the first drugs. It's been out since 1957 and is the mainstay of all chemotherapy that I still use today. So we use it better than we did in 1957. But 60 years later, it's still the mainstay, which is part of the reason you could say we need to improve it. This is the closest I get to Brent Allschlager's video, which is a picture of someone getting chemotherapy. Because when people really think of chemotherapy, frankly, this is what we think of. It's a bag of fluid that's running into an IV. That's what everyone probably sees chemotherapy as. I'm going to mention a little bit about two regimens because I'll show them on subsequent slides, and then a picture that I stole off the internet. So the two regimens which you'll hear about in today's world, and people will say FLOT and FOLFOX, and what does that really mean? So oncologists are, I guess, good with names, so we just take the names of drugs and we kind of throw the letters together in hopefully a decent order. And because all drugs seem to have two names, they have a trade name and they have a generic name, we get to pick at least usually one of two letters. So docetaxel has the trade name Taxotere, so you can put a T in there, and then it's just these drugs, oxaliplatin, leucovorin, fluorouracil. And FOLFOX is this thing called folinic acid, which I should actually point out is the same thing as leucovorin. That drug has like 3 or 4 different names. So we come up with letters and we put it together so we think it sounds good and everyone else thinks it just sounds like gibberish. But the FLOT and FOLFOX are two regimens that are commonly used. And the reason I have this picture here is because it shows a lot of what people actually have to go through with chemotherapy. So I didn't know how many people here have had someone who has actually gone through chemotherapy, but to give you the brief rundown, people often get something put in this side of their chest called a portacath. It's something that goes under the skin and makes it to where you can come in, get plugged into an IV, and then get unhooked easily and not have to be digging for veins. So those make life better. When you're accessed, you put this little special IV in. For most of these regimens, that it says here day 1, those are all drugs that are given in clinic. And then you leave with this little portable pump, which there's an IV going, and the pump's in this bag over here. Usually less color inspired, it's just kind of a black bag. But you get chemotherapy that you wear with you for over about 2 days. If anyone's going to actually get me, this actually should be 46 hours. I typed it in wrong, but it's about 2 days. So people get the chemotherapy, they come in on, we'll say, a Wednesday, they get the drugs for several hours in clinic, and then 1 to 2 days they're wearing this pump, and then you come back about 2 weeks later. So kind of a Wednesday, every other Wednesday would be the starting of cycles. And that's how oncologists also think. We think in medical oncologists think. We think of cycles of chemotherapy. So I guess the question becomes, why give chemotherapy? So though you just heard after you have a surgery, and we're going to start there with the chemotherapy aspects, it's a necessary step, but it's not necessarily good enough or sufficient to really cure everybody. That would be ideal, but it doesn't. And neither does chemotherapy adding to it. But what happens is if you just do surgery alone, and depending on the stages, how well the outcomes are, these people will be fine, their cancer wouldn't come back. And then we give chemotherapy to kind of help this middle group. And that middle group that I put in the blue here is a group that after surgery, if they get chemotherapy, or as I'll show in a minute, if you get chemotherapy before and after surgery, it improves your odds that your cancer doesn't come back. So it becomes a bit about statistics and groups of people, but the goal is this adjuvant is Latin to help. So you're giving chemotherapy to help the surgery. And then unfortunately, after you give chemotherapy, some number of people, after surgery and chemotherapy, some number of people, their cancer still comes back. So if someone has cancer and let's say they had the surgery first, you still give all, in this 100 people chemotherapy, and then some of them were going to be fine. Some of them you actually help with the chemotherapy, and some people, unfortunately, it still comes back. Right now, we're not even smart enough to predict who all those people are, because ideally, if I could do anything at the moment, well, I guess if I could do anything, it would be to get the whole bar green. But failing that, I'd like to just give those people chemotherapy, but we're not there yet even. And this is what oncologists look at most of the time, is curves that look like this. And what the curve is showing, for those who don't look at them a bunch, is this could be 100 or 1 as it does it that way. So on day 0 in a study, everyone who entered the study is alive. And if you said like this was people who just had surgery alone, and then it looks at time as you go out, and this is, I guess 72 months is 6 years. What happens to people? And every time the line drops, in this case, someone died. So the more you can move, in this case, the red line up, then the more people we're helping. And this is looking at perioperative chemotherapy, so it's chemotherapy before and after surgery. which is where trying to figure out who to help. It's usually people with more advanced disease. And in today's world, with endoscopic ultrasounds and CT scans and PET scans, you can do a pretty good job of staging people and figuring out, which people to have a higher risk of relapse. So this is what we look at, and our goal, as I said, is to eventually have a line that would, in theory, go right up here, and then people wouldn't die from their cancer. So when and what of treatment? So perioperative therapy really means you're going to give chemotherapy before and after surgery. So it's neoadjuvant, adjuvant therapy. The two main regimens that people really talk about today is what I showed you on that other page, FLOT and FOLFOX. So those are regimens that come with a pump. They're given every 2 weeks. Roughly, most things I do, we give about 6 months of chemotherapy. In perioperative, we give 3 before and 3 after. The next thing, and I know you had a talk on radiation oncology, and you're like, Andrew, you're not talking at all about it. Radiation is quite useful. I would say it's a little bit more esophageal, and lower esophagus is where it's used a little bit more because it's somewhat easier, I think, to radiate the area that the cancer goes to. So that's where you pretty much definitely use it. And the regimen there is usually something called carboplatin plus paclitaxel, though there is also data for this regimen called FOLFOX. And at least I have more pictures where you have radiation, and from my world, it's all chemotherapy. But in truth, in this thing, I think radiation is doing most of the benefit, and the chemotherapy is just making the radiation work better. And then after you would get that, that's usually done first, and then you would get surgery afterwards. If we get, in today's world, I'd say that's the most common approach to do it if you're going to do chemoradiation with surgery. But sometimes we think someone has an earlier stage of disease, they get their surgery, and then you find out they have a higher stage of disease. You can indeed give the chemoradiation afterwards. And then there is some more towards gastric cancer and more from Asia, there's the idea that you could just give chemotherapy afterwards. So there's a lot of different ways that we're sequencing all of this. And what you can see is that there's not clearly, I would say, a better way to do it. There's very little comparisons between just doing the chemotherapy versus doing the chemoradiation. In truth, I would say most of the time, the numbers look a little better that if you can get chemoradiation compared to chemotherapy, it looks a little bit better to do all 3 parts of the treatments. But it depends a bit about where the cancer is and stuff like that. So I'd say if it's more in that junction between the esophagus and the stomach, I think we lean more towards chemoradiation. And if it's more stomach and less at that junction area, I feel like we do more perioperative chemotherapy. But that's kind of the way we do it. So that's all chemotherapy before and after surgery. So then there's, of course, a situation where cancer has either come back and has spread, or it's metastatic or has spread from the beginning. And in that setting, the question is what chemotherapy to give. And in what's called first line, or the first treatment you get, there is not well-defined answers, though what the world seems to be leaning towards in the US is that you get something called 5-FU or fluorouracil, which capecitabine is an oral equivalent of 5-fluorouracil, or you get a platinum, which is cisplatin or oxaliplatinum. There's other drugs you can do, but that's the mainstay of what most people do. In the second line, and I'll show you some of this, and we'll get to targeted therapy in a minute, there's 2 kind of options. The first one that would be the best, or the most FDA labeled, not necessarily what everyone gets. This is called Ramucirumab, which is a blood vessel growth inhibitor. Everyone just calls it RAM for short. And Paclitaxel with chemotherapy, and I'll show you a little bit more about that in a few minutes. And pembrolizumab, if your tumor is something called MSI high, or microsatellite unstable, and I'll get to that in a few minutes because pembrolizumab is also called Keytruda and is immunotherapy. Third line, there actually is now third-line treatment options. So the immunotherapy for just most people, potentially with gastric cancer, can get immunotherapy potentially, and we'll talk about that in a minute. And then there's this pill that is a little bit, in truth, like 5-FU that can be given as a third-line option. So there are at least 3 different things that people can get today in order. So I'm going to talk about a minute about side effects of chemotherapy. Sorry, real quick. I don't have a clock. How am I doing on time? I'm good. Okay. So side effects of chemotherapy. So everyone thinks of chemotherapy as targeting fast-growing cells, and there's a whole long list of side effects. But what really happens to most people is, one, it does affect your bone marrow, so you get low blood counts. Neutropenia is low white blood cells. There's in truth only a small risk of developing infections with that. You can get anemia or low red blood cells, which can cause fatigue. And thrombocytopenia, big fancy word to say low platelets, which is what stops you from bleeding. Those usually also don't go low enough to cause any problems, but are laboratory abnormalities that we deal with to monitor chemotherapy. I think of chemotherapy that I give is it's targeting the GI tract, because these are GI cancers. So the GI toxicity is one of the major events, which comes down to nausea, vomiting, diarrhea, and constipation, which sounds a little bit like you said diarrhea and constipation. Diarrhea is caused more by chemo, but we have a lot of good medications that prevent the nausea that cause constipation. So when people are going through chemotherapy, I feel like most of my time, this is kind of the box that we're talking about how to manage. And in truth, it's usually reasonably well managed, and people are able to get, oddly enough, into a routine as you're going through chemotherapy to get this done well. I have patients who are, the first 3 days I'm constipated, the next 3 days I have diarrhea, and they know which medications to take, and then the next week they're usually feeling even better. You can get mouth sores, continuing kind of the side effects of the GI tract. And then there's some more specific drugs that cause some more unique side effects. Cisplatin can cause hearing loss. It doesn't seem to be that big of a problem, but people might get actually hearing tests and track that to make sure it's not causing a problem. Oxaliplatin, which a lot of people get, you're sensitive to cold for a few days. So like if you put your hand on a cold glass or you drink something cold, you can feel it in your throat, you can feel it in your fingers, and then that lasts usually for 2 to 5 days up front and can start to get longer. And then over time, it can build a little numbness and tingling that doesn't go away. On the plus side, if you're getting it in the around surgery to where you're going to stop it, 4 years out, it's only about 1 of 10 of people who still have numbness and tingling. So it does get better over the long term. And docetaxel can also cause some numbness to develop. Hair loss, in truth, for most of these drugs isn't a guaranteed event, though for docetaxel it does usually cause hair loss, and a few of the drugs are acutely, or in the short term, difficult on the heart, but not long-term side effects. So that's the side effects of chemotherapy. We have a question panel, so I guess I'll wait for questions. Targeted treatments. So what do we mean when we say targeted treatments? So I talked about chemotherapy as being something that attacks DNA and the way cells divide and has side effects more general related to that. Targeted therapy, to some extent, has other side effects and is less targeted, I would say, from a patient perspective than from my perspective. But the idea is that, in this case, what this picture is showing you is this is a cell, and that's the cell membrane. And all over cells have proteins that can receive signals from the environment. And this one here we're targeting is called HER2. And trastuzumab, also known as Herceptin, which is used in breast cancer, is also used in gastric cancer for HER2-positive tumors. So it's a monoclonal antibody, and for anyone who wants to know, any medication that pretty much ends in MAB is a monoclonal antibody, and then there's a complicated system to how to make up the rest of the words. Lapatinib is something that can target the inside, kind of where if this is where it signals, this is where the mechanics are in the cell of how it works, and you can block this up. And then there are some other drugs that are listed here that are all about HER2 targeting. Herceptin or trastuzumab is the only one that's been shown to work in gastric cancer. Part of what happened is that these drugs were used in subsequent lines of therapy in breast cancer, so it's what they tried to do in gastric cancer. And now there's some data that HER2 gets lost in gastric cancer after it's been treated, so it doesn't seem to persist as long as it does in breast cancer. So these drugs might still get moved up further in the future. And then something else to mention on this slide for targeted therapy is this TDM1 is trastuzumab, attached to, in truth, a very potent chemotherapy that you couldn't give someone systemically. The idea here is that this would literally bring right to the HER2-positive cells this potent chemotherapy that then would just go into the cancer cells. So it's another kind of targeted therapy called an antibody-drug conjugate. So there's an antibody, and then there should be a drug on it. So what oncologists do is reasonably simple. We think more is better. So we did a study where we took 2 chemo drugs, and then we added trastuzumab to it if patients were what's called HER2 positive, which is being that's overexpressed on the cells. And then we look at these curves, and if we move the curve that way, and it's statistically significant, which is something the stats people figure out, and this number here usually has to be less than 0.05, then we think we did something good. So what do you get when you add to it? If you look at ORR, stands for overall response rate. That's kind of saying in 2 months, the first CAT scan, did the cancer stay the same, or did it shrink, or did it grow? Response rate would imply that it shrunk versus disease control, which would say it was stable. So it improved the odds that there was actual shrinkage. And then we look at something called progression-free survival, which is to some extent how long you're on chemotherapy for before your cancer gets worse. And then, of course, overall survival, because our goal is to make people live longer. So, oncologists never like to quote numbers to patients, but the studies all come out with a median, what's important is a median is a middle of the road. Unfortunately, what really happens is some people probably aren't all that much helped, and some people get more benefit, and then we get this number that's in the middle called the median. But it's what we use to compare things from one to another. So the truth is, unfortunately, for metastatic disease, the median overall survival is at the moment about a year for how long patients live. Looking at targeting something else, VEGF is about blood vessel growth. The V stands for vascular. So this is also on cancer cells, and VEGF floats around in the bloodstream. And there are 3 drugs that are really listed here. That 2 of them attack VEGF, and 1 of them attacks the receptor. And this drug here, Ramucirumab, is something that's also approved and used in gastric cancer in the second line that I showed you on that earlier slide. I call this the tale of 2 trials, because part of it is depending on how you design the trial and what you look for statistics, because I'm not sure which one necessarily looks better, but this one was technically a negative study, though it seemed to add about 2 months of survival. This one seems to add, in truth, a little bit less than 2 months, but this was a statistically positive study. So this got Ramucirumab approved by itself, and then they combined it with chemotherapy, and it's a second-line study. So this is after people have been on chemotherapy, what can you give them next? And the answer is Ramucirumab with Paclitaxel, because the response rate is only 1 out of 3. That's actually shrinking. Though most people, 80%, had some amount of disease control, so it bought time. Though it wasn't very long. And for people who went in studies, it's less than a year that these people who went on study lived. So you can see at the beginning, there's people you don't seem to help differently. Then there's this gap, which is great to have, because these people did better. And then, unfortunately, it all comes back down together. Targeted therapy side effects are a little bit different. So Herceptin is known to affect the heart. So there's a little bit decrease in heart function, so that gets monitored. It's reversible if you stop the drug. You can also get infusion reactions. And then patients are commonly commenting on runny noses. Ramucirumab can increase your risk of blood clots. It can also worsen your blood counts, which makes it sound like standard chemotherapy, and sometimes can increase pain, oddly enough. So now I'm going to go to my last topic of systemic therapy, which everyone gets very excited about, and we're all trying to figure out how to work better. It's about immunotherapy, so I'm going to back up for a minute and talk about the immune system. So the immune system, that part I'm going to talk about, is the things that are called T cells. T cells are the cells in your body that fight things like viruses. So the way the T cells work is that you have some amount of immunity built in, and then you also have some amount of T cells that can develop and adapt to what they find. So if you think of a virus for a second, a virus gets into a cell, and your body has this whole system to process and put proteins on the surface, and then your immune system goes around checking it out. When it finds something that it shouldn't see, the T cell then tells that cell to die, and then that cell should go away. And that's what happens with viruses, and eventually the virus is cleared out of you. Cancer cells can sometimes be recognized by the immune system, and if the job is done, then your immune system fights your cancer, and you never actually probably know you had cancer because it went away. So if the cancer is going to develop and your immune system is going to respond to it, it has to block that. And the way it does that, okay, this is what it's all about, the processing. The way it does that is there's these things called PD-L1, and it binds something called PD-1, and those stands for programmed death. So what happens is the T cell comes in, sees the cancer cell, it activates this thing called programmed death 1, and then the T cell dies. And you have this built-in system so your immune system doesn't destroy you, which your body can't actually do, which is why you have, there's autoimmune diseases where your immune system attacks itself. This is why we have a system to prevent that, to decrease inflammation once it gets going. So cancer cells hijack that. So they made antibodies that block this interaction between that. So if you have a T cell that can see the cancer cell, you can block these interactions, and then the T cell can do its job and kill off the cancer cell. So the interesting thing, or not, I don't know if it's, the interesting about of immunotherapy to some extent is it takes a little time to work because you have to boost your immune system. So this I put in here to say, why do we not just jump to immunotherapy? Part of it is that this was a study where they compared chemo versus immunotherapy. And what is you can see that up front, some people don't respond to no matter what you do. Then there's this gap, and the gap here actually shows chemotherapy being better. This chemotherapy, if it's going to work, works quickly. It's on the first 2 months, it starts shrinking cancer right away. But then, of course, chemotherapy stops working, and that seems to be when the immune system gets better at kicking in and holding out, because your immune system, you keep and you train it. So obviously, people are looking at the idea of combining the two for two reasons. One, then you would move things out to this area, and as the immune system would kick in, you would hopefully get people who continue to do better for longer. There's also the idea that if you're putting chemotherapy in with immune system boosters, the two would be synergistic, meaning that you would get more than just an additive effect. As the cancer cells are dying from the chemotherapy, the immune system would see more things and then have a better chance of responding. And then if one drug in immunotherapy works, the question becomes, does two drugs work better? And it's not really 100% sure in gastric cancer at the moment, but the idea would be that you, once again, are just trying to continue to shift the line towards more people surviving. Right now, immunotherapy seems to, in truth, really help about 1 out of 3 people when it comes down to the people who qualify for it. So immunotherapy side effects, this is really more of a picture, but someone said it best, I think. If you can point to it, it can get inflamed, and that's what immunotherapy does, is it boosts your immune system response, so you can get rashes or inflammation of the skin, you can get inflammation of the lungs, inflammation of the GI tract, inflammation of the pancreas, and we can keep going through different organs in your body. So it's more of a risk of something getting attacked by your immune system than the typical chemotherapy side effects of like nausea, etc., and things like that. So my summary is that chemotherapy is given before and or after surgery with or without radiation to improve survival. That summarizes that there's a bunch of different options of how to use it all together. Targeted therapy improves outcomes with chemotherapy, and we have new agents that people are working on targeting different things to try and get those to come out. And then immunotherapy is here for stomach cancer. There's some group of people who can get it based off of how much immune suppression their cancer seems to be having. And there's clearly room for improvement since we want to help more than 1 out of 3 people. That's my talk there.